Good afternoon, everyone. We are still waiting for a few more to join the call this afternoon. If you are a committee member, if you would put your name in the chat, or if you're a committee member who's on the phone, if you would unmute and let us know that you are here. We should get started here in just a few minutes. Thank you. Good afternoon to those of us who have just recently joined. We'll be getting started here in just a moment. If you are a committee member, if you would put your name in the chat, let us know that you are here. If you are a committee member who is on the phone, if you would unmute and let us know that you are listening in. We should get started here in just a moment. Thank you.
Hi, Sharon. This is Kim Danzy. I'm here. Sorry I'm tardy.
Oh, no worries. Thanks, Kim. Welcome. Okay, and Michael, I believe you can get started. We do have a quorum by my count, so.
Very good. Thanks, Sharon, and welcome everyone to our April 2024 MAC meeting, Medical Care Advisory Committee. And we'd like to begin with our meeting minutes from last month, if people have had a chance to review those and like to discuss any potential changes, or if there aren't any, to make a motion to adopt them.
I'll make a motion and I'll second it. How about that?
Great, thank you. And we will, as usual, vote by silence. If anybody opposes the vote, please let us know. Okay, so we'll consider the meeting minutes adopted unanimously. Thank you. Okay, first item on our agenda after that is our Notices Committee quarterly report. So we have several members of the MAC as well as members of the departments and others working on our notices that go out to Medicaid patients, recipients, beneficiaries. And we asked Rachel Craig if she would give us an update of this quarter's meeting. Thank you, Rachel.
Yeah. Okay, so I'll just give a quick update. Full disclosure, it will not be 20 minutes unless if you want me to talk for 20 minutes, which I don't think anyone does. So just as a quick review, right now we do have an updated flyer on the purpose of the MAC. That is available and online. I will drop the link to that in the chat if anyone is interested in checking that out. And then one of the bigger items that were worked on was the Medicaid CHIP and application process flyer. This is to kind of give members a little bit more information on what the process looks like, and a flow chart, I believe was sent out today. I haven't had a chance to look at that email. So if someone like Gina or Michelle could let me know if Gina's here or Michelle, if that was sent out today. I think it was. And that flyer will be reviewed at our May meeting. Michelle's giving her a thumbs up. So it was sent out. I haven't had a chance to look at it yet. But I presumed that what it was, it creates a flow chart that kind of breaks down the process into 3 steps. That DWS will review the application to make sure it's complete. 2 would be the verification and paperwork gathering process. And then 3, the decision process. And then that kind of created process flyer is going to, I think I said this, reviewed in May. Then the other kind of big item that was worked on was the notice survey. So a notice survey was created by folks and decimated by Gina Boren that goes through kind of some of the big forms that that are used throughout the process. It was a pretty hefty survey. The notices, some of the notices that I asked about were the verification checklist, review complete notice, approval denial, closure changes, and those kind of notices. And there were also some forms also reviewed as well, if I remember correctly. I did fill it out. And the survey results are still being compiled, and they'll be shared in the May forms meeting. That's, I think, most of it. I don't know if there's any more forums members that want to share anything, or forums committee members that want to share anything, but that's the bulk of the updates right now. Steph was full disclosure, Steph was able to attend a few more meetings than I was, so she does have more information, or at least firsthand experience.
Oh, thanks, Rachel. I guess I wanted to just ask and allow the opportunity for you or anyone from the agency to just so when we did the report, the first report on this committee, there were some suggestions for improvement, some requests made, and I just wanted to see if we could, as we do these quarterly updates, I just hope that the requests for improving the process don't fall through the cracks, because a lot of those came because we do actually need to get more beneficiary engagement in the process if that's the goal of the committee. And so I just wanted to surface that and just say that, to my understanding, we just haven't, anyways, the agency can speak for themselves, but I mean, there just hasn't been we haven't gotten through all of that list, and it has been a few months, and I know it's been really busy, but I do just want to surface that would be a helpful thing if we can just stay on top of what actually happens with the request for improving the process of the actual notices committee, in addition to the tasks that we as notice committee members are doing with the agency every month.
Yeah, I'll just comment, Stephanie. Noted, and we will be tracking and presenting those in the meetings as well. And so I guess with our future presentation, we can incorporate this into part of the presentation. When one of the members gives an update, we'll make sure the department also gives an update on some of those larger picture items as well.
Thanks, Jen. And do you know when we might also get the big action plan, just the overview of what is y'all have kind of referenced it for several months. So I'm just wondering if when we're going to be able to see that.
Are you specifically referring to the larger project plan and the goals and objectives of what we'd like to accomplish with this work?
I think so. I mean, it was something that's been, I don't know what y'all call it, but I think it's just that bigger plan that you have a vision for how you actually see the process to go long term.
Sure, absolutely. We're happy to bring that next month. So we'll make sure that gets on the agenda and is presented to the MCAC.
All right. Thank you for the report, Rachel and Stephanie.
Thank you.
Right. Then Sharon, if you'd just make a note of that, so we make sure we keep track of that for next month's meeting, that would be helpful. And it probably will be the June meeting, because next month is our public hearing, and that usually consumes most of our time.
Hey, Michael, sorry, can we at least then get it at the next notices meeting? It's been months now that we've been it's just been pushed off for a while, and I just think it would be respectful of our time if we had that at least presented to the notices committee and then maybe the MAC in June, just so that we can give feedback and understand the process by which our work is contributing to not just, I don't know, just the bigger picture of all of this, because that's something that I think, I don't know, it's just been asked for a while now. So I'm just hoping that we can get that at least to the notices committee by next month.
Okay, and just looking at the notice committee timeline, that is, where did that go? So that's the second week of each month, if I saw that correctly, but it's disappeared from my screen. There we go. So second Tuesday of each month. So does that seem like a reasonable timeline, Jen? Because it'd be second week of May, probably the 13th or 14th-ish.
Yeah, happy to. This, I mean, it can be distributed within a couple weeks. That would be fine.
Okay.
Thank you.
Great. Okay, next we have a request on the implementation status of items that came out of the 2023 legislative session, so just over a year ago. So we have a presentation here from Brian Roach, and this was one of the attachments distributed in preparation for the meeting. So Brian, we'll hand it over to you, let you take it from there.
Thank you, Michael. One moment while I bring up the slide. All right, thank you. I was asked today to present, as Michael mentioned, on the implementation status and also utilization experience that we've seen so far on the items that were passed out of the 2023 legislative session about 15 months ago. So I also, in this effort, was mindful of the fact that May budget meeting is going to be next month. And so I did try to bring in some of the prioritization that came through this body and reference that of how your contributions are important, and did ultimately kind of coincide with what was passed to some extent. So that bearing in mind, the very first is postpartum Medicaid coverage amendment. This was passed as Senate Bill 133. It was the #1 MAC priority when we prepared going into the session. This was implemented January of 2024 and did guarantee 12 months of eligibility coverage after a pregnancy ends. There was an automatic conversion of eligible members. Maybe individuals were currently pregnant or part of their first 60 days post-pregnancy. When the program went live, they were automatically converted over to this benefit so that they would receive up to 12 months or 12 months after the pregnancy ended. It also did extend for CHIP, although they don't have a separate CHIP pregnant indicator, at least easily accessible to me. So I just want to mention that they also get this benefit. They're just not shown in this graph. The graph shows everyone on our Medicaid pregnancy benefit. So it's hard to just parse out the individuals that are in their 3rd through 12th month postpartum in this work, but the graph clearly does show the enrollment increase as individuals were not closed and were maintained on the program beginning January 2024. Next to cover is our state CHIP program, or as it was passed during 2023 was the Children's Health Coverage Amendments, Senate Bill 217. This was the #2 MAC priority as we prepared for the session. It was implemented January of 2024, and it is growing. We are still seeing about 50 to 100 members each week, sometimes a little bit more. And we have prepared outreach materials, ultimately expected to serve up to 2,000 members, and we're still growing to that level. But we're really happy and a lot of community support for this. And we continue to use whatever outreach methods and stakeholders can help us advance the outreach. We're happy to work with you to share those outreach materials. Moving on is autism coverage amendments. This was Senate Bill 204. This was implemented back in July of 2023, and this is to allow applied behavioral analysis for adults. It's been a benefit for what we call our EPSDT, early periodic screening, diagnostic, and testing eligible children up to age 21. It's to provide that same benefit to adults. We have seen growth month over month, almost 40 adults served as of February, and about 5 or 6 providers. These are not necessarily new providers to the system, but providers that are offering it to adults. So we're seeing some growth there. Next was a funding item, which was to increase acute and continuous private duty nursing care. Private duty nursing is primarily a benefit for EPSIT eligible individuals. This was implemented July of 2023. So the graph on the right does include some prior months to the implementation for context, but what the benefit allowed for was to allow for both the continuation and the acute phase of private duty nursing. The acute phase is, for example, right after release from hospitalization, allowing 24-hour private duty nursing to be available. Previous to this policy, it was allowable only for 7 days. This allowed us to increase it to 14 days. And then as well for continuation after that acute phase, the number of hours that an individual is eligible is based on an acuity grid. And there's a acuity workup that allows individuals to determine what number of hours are eligible to them. For each of those acuity levels, it added 4 available hours to them. What we have seen so far, and what you can kind of see from the graph, is that it hasn't made a large difference yet in the hours per member per day. Right, we're right around 6 hours per member per day. And we are, as mentioned in that last bullet point on this slide, continuing to do work on the acuity grid to see whether there are certain conditions, certain conditions that could result in kicking individuals into a higher acuity and therefore eligible for more private duty nursing hours. So we're continuing to work through this with our stakeholder community and expect to have an update on that policy. Moving forward is the recreational therapy Medicaid coverage amendments. This was House Bill 315. It was just implemented in January, so we don't have a lot of utilization data yet. What we can present at this stage is that we do have 14 recreational therapists enrolled with us. There are, by what I was able to determine based on like our national provider registry, there's around 50 or so recreational therapists in the state, just for context there. So we've enrolled about 14. Recreational therapy is covered when it's part of a treatment plan and referred by a mental health therapist. And it's designed to restore, remediate, or rehabilitate a member's level of functioning. So we're excited to see some growth in that policy as well. Next to cover is providing Medicaid annual WellCare visits for adults. This has been a cornerstone for children, but in 2023 legislative session, we got funding to cover this for adults. This does align well with One Utah Health collaborative goals to increase the use of prevention within Medicaid. I think we can all recognize the value of that. And we do expect some future quality measures to represent the value of this, both in managing chronic conditions and preventing chronic conditions. There's a lot that we do envision with future corset measurement that could bear out the benefits that we're just starting to utilize right now. So this is an exciting area. Next to cover is medically complex children amendments, which was House Bill 290. It was implemented in July 2023. What it did at the time was increased our cap for medically complex children waiver, raising it from 710 to 900. At the time, we were not at the cap, but it allowed us to, as you can see on the graph to the right, we have gone above that 710 number, and we're still increasing to this day. It also made a change to the waiting list provisions so that prior to this, an individual's score in the medically complex children waiver scoring tool, if they, through their enrollment, decreased their score and their acuity, it could result in them being removed from the program and being replaced by somebody on the waiting list. The provisions of House Bill 290 changed that so that as long as they remained eligible for the waiver, they would remain enrolled on the waiver. So we're continuing to increase our enrollment in the waiver and are projected to reach the current maximum of 900 sometime in the next fiscal year. Next, there are a lot here that don't really bear out well in some of the data because they are reimbursement changes, but they're just recognizing that 2023 was a very productive session. It included many of these reimbursement increases for many of the providers that are vital to our benefit. So the ICF and waiver rates increases, bringing again this back to this body. This was part of number 3 and number 5 MAC priorities that year. Caregiver compensation was number 4. A whole lot for autism rates, some more in waiver rates, air ambulance, hospital assessment amendments, but there were quite a bit on the reimbursement change front. And then finally, there's more to come, as there were also 3 waiver amendments that resulted from the session and are currently awaiting CMS action. That is the family planning waiver, dental waiver amendments, which will provide dental benefits for everyone that currently does not have them, which is our largely our adult population. And then the chronic condition support waiver, which will provide additional tools for individuals outside of an ACO to manage their chronic conditions. So, yeah, happy to take questions at this time.
Sorry, that
Great.
was so fast, Brian. It's not an aggressive question at all. I was just wondering, do you have any insight, or can you share any insight into specifically the family planning one? I thought that one was like pretty standard language. Is that just, I mean, I know sometimes you guys can't say much. Is that just like CMS, no offense, being slow?
Yeah, I don't know, Jen, if you want to speak, but I mean, largely there's a process for review, and there are a lot of prior waivers that we have in the queue for them. We do not expect, like, when CMS is able to work on family planning, I guess I'm hopeful it won't take long, but it is just a process we have to work through with them to bring it to the top of their priority.
Yeah, that's totally fine. I just was like wondering, so if that makes more sense if they haven't even like started to work on it. I thought it was just like, sometimes things take a while. It was just with this one, it was like, it seemed pretty standard. It wasn't like something that was kind of novel, like maybe the dental arrangement or the chronic conditions waiver. So that's why I was wondering, but that makes sense. Thank you.
Yeah, thank you for your question. Any other questions?
Okay, a lot of good work. Thank you, Brian. We appreciate the update on the implementation as well as some of the uptake and the experience of those who have been able to start taking advantage of the new coverage. That's great. Okay, next on our agenda, we have Michelle Smith to give us an eligibility and enrollment update, and this should be our final unwinding report. So, Michelle, let's have you take it away.
All right, thanks, Michael. Hi, everybody. I will get my computer to present here. Give me 1 second. Okay, can you all see it? Perfect. Okay, so this is, as Michael stated, our last and final unwinding report. To start off, here is a snapshot of our total enrollment right now. We are at 345,622 individuals as of the end of last month, and 0 individuals being kept open, which means we have gone through our unwinding cohort of individuals for reviews. I'll mention a little bit more about the reports as we go through this report, but as always, I start off with the snapshot so you guys can see kind of where we currently are with the work. So moving down, we are in our final month, the end of April. So April 30th of 2024 will be the end of the unwinding period for the state of Utah. This has been a very large effort. We did start back in March of 2023 and have gone through, over 500,000 individual reviews for individuals in that 12-month period. So very massive effort that we had undertaken along with Department of Workforce Services. So here for the month of March, at the end of March, we had experienced 18,000 closures. I've kept previous information on this report just so that we have the standard language and just for reference for you all. So I won't necessarily go through the standard items each time. As of note, we did update our unwinding data dashboard on the 16th, so just a couple of days ago. I'll put a note on here as well. I believe that the document that was shared with you all by Sharon showed the 12th. So I can get this over to Sharon to get resent so it shows the corrected date. We did have some difficulties on trying to finalize our data for that. So that's why we usually have that refreshed by the 8th. And that's why we were a little late updating that data. We sent our 13th CMS report. So we've sent across a baseline report as well as 13 other reports. In that CMS report, we reviewed a total of 20,525 individuals. 9,525 of them stayed on Medicaid and CHIP. 244 were no longer eligible, meaning over income or assets or another eligibility reason, and transferred automatically to the federal marketplace. 7,854 of those individuals were closed for paperwork reasons. This next section right here talks about the pending individuals. I know I'd mentioned that a couple of meetings ago. CMS had reached out to states and wanted us to start reporting outcomes for those pending reviews in our monthly report. So that's what these numbers are, those pending reviews that had occurred in the month of December in the January report. So we will, even though this is technically the last unwinding report we'll do, we do actually still have 2 more what CMS is terming as cleanup reports that we will send to them with those pending reviews and those outcomes that we'll go over. And of note, I'll kind of jump ahead here towards the bottom on next steps. CMS has mentioned a few times that they do plan to continue these monthly reports from states. They have not released what those will look like, what information will stay the same or what might be different. But as soon as we receive that guidance, we will definitely be sharing that with you all, making you aware of that. But they have expressed that they do plan to continue the monthly reporting from states. So I did want to make you all aware of that. Yes, Stephanie.
Thanks, Michelle. Does that mean that we will continue the dashboard?
That's a great question, Steph. And Jen, did you want to answer that?
Yeah, Stephanie, we're in conversations around what type of dashboard presentation we would like to pursue going forward. So that is still under discussion. The plan at this point is to keep the current dashboard up for the next few months while we have those discussions.
Thank you. And then one last question, Michelle. So you say this is like the final report, but the like the end report that was a part of the original plan. Maybe you're going to go over that, but just curious when that might be presented.
Yeah, no, great question, Stephanie. I was going to bring that up next, so it was a good segue. Definitely, I know in our last meeting you had a question around that. We are actively working on that report. Obviously, we still have, like I said, the end of this month and 2 more cleanup reports that will occur. So the data hasn't completely settled yet. So we're trying to, ensure that we truly capture everything and in the right, the right numbers, all of that. So we are actively working on that report, and we'll definitely give this committee a heads up on when that will be ready to present. And I don't know, Jen and Brian, if you had more that you wanted to offer there, but we do plan to present that here.
And it's looking like June or later at this point with the May meeting. So I think it'll just be coming in a future meeting.
Okay. And if it's okay, Michael, I will go ahead and present again just our online dashboard. Again, for those of you who are not familiar with this, you can find it at medicaid.utah.gov/unwinding. Like I said, we did refresh this information on the 16th of this month. And if you look over here at this last month's data, again, this is based off of the monthly CMS report. So it gives you a percentage on each of those outcome areas of what we reported to CMS. So you just hover over that bar and it gives you that percentage. One thing I wanted to point out, we have seen an increase in our ex parte reviews, which is really exciting for us in DWS. I mean, great work and effort has gone into this, both from DWS teams and our policy unit who's participated in the testing and building of those requirements. So we're really excited to see that increase. As you all know, the more individuals that we're able to review through the ex parte process that are eligible and keep them eligible, the less likely they're going to fall through the cracks, right? And so that's kind of our hopeful outcome with automating ex parte, and we're starting to see that increase, which is great. If I move over to the Medicaid to CHIP tab, just real quick, you still see there's movement happening each month with the activity of doing reviews from Medicaid to CHIP, members moving. We have this tab for members that shows all of the new individuals that are coming. So again, anyone who has not either been on Medicaid or at least not been on Medicaid or CHIP for the past 3 months, these are all the new members coming on. And then these are the individuals who we are deeming as returning members. So they have had Medicaid in the previous 3 months and have come back. And then this is other DWS activity for those of you who are interested to see all of the great work that's going on over at DWS. And then this is our presumptive eligibility. This has kind of been dipping down a little bit. You know, we did see the increase obviously when unwinding started, and then it's just slowly starting to come down a little bit. So maybe showing some signs of some hopeful stabilization and ensuring that we have, you know, eligible individuals onto the program and, you know, not having to, you know, rely on coming through that presumptive door, right? And maintain that eligibility. And then we have our call volume, monthly call volume, slightly decreased from the last month, the call volume. Average wait times is the same at 20 minutes. And then our call abandonment rate went up a bit from 21% to 26%. So again, all of this data is available on the dashboard for any of you who are interested. And I will just stop presenting and then just pause and ask if there are any other questions. Yeah, Rachel.
So I had asked DWS this too, and I know it's a policy that needs to come from you guys. So DWS is doing some ex parte reviews based on SNAP and TANF data, but I remember there was a flexibility during unwinding that could have been taken. I believe you all said that you were looking into doing that permanently to allow for more use of SNAP and TANF data for ex parte reviews. I just wanted, like, do you guys have like a timeline on that or anything? Just wondering.
Yeah, that's a great question, Rachel, and pretty timely. We actually have still been waiting for further CMS guidance. We do want to pursue adding that to our verification plan where it's a data source. So for example, if I completed a SNAP review 3 months ago and I had to request check stubs from that individual, and I'm coming up for my Medicaid review now, and it's the same thing. Maybe I don't have access to your income through another data source, such as the work number or, you know, so forth. I can rely on those check stubs that were utilized for that SNAP review. What we're waiting on clarification from CMS is, do we take the check stubs and do a best estimate for Medicaid based off of those check stubs, or do we use the best estimate that SNAP used and use that as our income for Medicaid, right? And so that's what we're waiting for further clarification from CMS on, and we're hoping we keep giving them signals to try to, you know, hey, you know, we need an answer. So yeah, we're definitely actively pursuing that. That would help for sure, especially for those cases in the example that I just gave. So thanks for that question.
Awesome. Thank you.
Yeah.
Okay, any other questions? I just had an observation as I was looking back at March of 2020 enrollments, and it seemed like we were at about 295,000 individuals. And now 4 years later, it looks like we've finished the unwinding with essentially a plus 50,000 net enrollees of where we were about 4 years ago. So not all the way back to where we had been prior to the pandemic and the continuous enrollment provisions, but I think that's just a good number for people to be aware of. It seems like where we were 4 years ago, go through the continuous enrollment and the unwinding, we're with Medicaid adult expansion having started just prior to the pandemic, that we're probably a net 50,000 enrollees on a monthly average over where we had been 4 years ago. So, okay, Michelle, thank you.
Thanks.
Yep. All right, so we'll let you off the hook. I don't know, we'll probably bring you back these monthly reports. I know you look forward to them each month, so we won't let you go a full quarter without providing some information, but we may scale back from the monthly participation in the MAC meeting. If we get some requests, we may just have an ad hoc report requested month to month if people have been missing having your presentations. So thank you for your work and all of the work at DWS for working through all of the unwinding big workload to get through, and hopefully we can now get back to a more stabilized approach to eligibility determination and program enrollment. Okay, Jen, you're up now for the director's report. So we'll
Great.
turn it over.
Thank you. Let me go ahead and share, and then I'll dive right in. I have several things to run through. I have two different presentations to share with you. So I'll start with just the general Medicaid director's report. I was asked to give an update on our audit status. As many of you know, we are in the midst of two unwinding audits right now with HHS. One is with HHS OIG. The second one is with the Office of Civil Rights. Wanted to give you the update, first of all, on our OIG audit that is more active than the OCR audit. What we know with our OIG audit is, first of all, just to give you an overview of what they're looking at, there are 140 case samples that have been pulled from our unwinding documentation that they are diving into. And they are kind of broken down across three different types of issues that they are analyzing the work. In this part of the audit, we are in just a technical dialogue where they're asking questions about what their findings are, and we're responding to those. And there's a lot of back and forth via email and some discussion as well, just live discussion over video connection. So that is ongoing and is actively occurring. One piece I wanted to share is that Utah is one of 4 states that is involved in this type of audit. The other states are Ohio, California, and Massachusetts. And the Ohio report from the HHS OIG was released last week. So if you kind of get a flavor of how the audit is running in the areas that they're looking at, theirs is got a similar flavor, although they have a different program, of course. But that was released last week. I don't have the link to that, but if someone does, we can throw it in the chat if it's available. The 3 types of issues that they are looking at in broad categories for these 140 cases are as follows. Number 1, errors that impact eligibility. Number 2, procedural closures that hold on. Procedural with, oh gosh, some of these I don't have written down very well. I'm sorry. I'm trying to answer your question, Stephanie. Procedural errors that where the person was put in the wrong strata, but there is no impact to eligibility tied to this type of issue. And the third item was around income and determination of income, where there was no impact to eligibility. So one of the issue types was associated with an eligibility error, and then the 2 other types were procedural issues and income issues. So that's where we are with this now, and just wanted to share an update on that. Not much to share with regard to the Office of Civil Rights audit. They did send us an initial request for data, which we did respond to. And since that initial request a few months ago now, we have not had any interaction with the OCR auditors.
What were they looking for? Sorry, Jen, I don't know if we got an update back then. So what information were they looking for?
Oh gosh, Michelle or Brian, could you give some of the details? I have not refreshed my memory on this. If not, then.
Yeah, it's Brian. Sorry, were you going to?
Oh, it's fine. I mean, you can contribute. I know there was a whole lot of demographic information. Some of the some of the data broken out by demographics. That was a large piece of it. And then policies and procedures. But Michelle, you may have a better memory.
Yeah, no, I think you're capturing it well. So they were just looking at those policies and procedures and, you know, how we were providing access to individuals with limited English proficiency and disabilities. So, yeah.
Okay, thank you.
Mhm.
All right, moving on to our 1115 waiver updates that we would like to share because our public posting is soon. We have 2 that we are working on right now, preparing for submission that came out of legislative session this past year. The first is our health-related social needs waiver, which will incorporate the housing services as well as medical respite service. And so that will be publicly available on May 2nd. There's also an addendum to the justice waiver. Of course, you know, the justice waiver was submitted 4 years ago, but we were able to make some changes after this last legislative session to align with CMS requirements. And so those changes are captured in an addendum to our original amendment, and that will also be posted on May 2nd. There will be opportunity for feedback to this, to the HRSN waiver in the May MAC meeting. I believe we were going to fit that in on the very busy agenda, Michael. And also we were planning to cover the changes that are incorporated in the justice updates. Now, note that the justice waiver did have and go through a public posting and a hearing process, public comment 4 years ago. So we do not need to move through those steps on this go round, but we still want to give appropriate public notice and allow you to give some time to comment through an informal process. So we'll be doing that May 2nd. And we also have so May 16th, it will be at the MAC. And then on May 6th, we will hold a public hearing if you're interested in joining that. So some good work moving forward with those 2 updates. Moving on to some items that Brian covered, which we did just complete with CMS regarding 2 additional waivers that we had submitted back from the 2020 general session and 2021 session. So I'd like to just cover those policies with you right now because these are actually going live on May 1st. Both of these services, both fertility preservation as well as IVF, in vitro fertilization, and genetic testing are services that are carved to fee-for-service. I'd like to just spend a moment and walk through them with you so you understand what these policies cover and how they can benefit Medicaid members who qualify for them. So as a background for fertility preservation, this is really specific to individuals who are diagnosed with cancer and going through a treatment that may cause a substantial risk of sterility or iatrogenics, infertility, in incorporating surgery, radiation, chemotherapy. So this policy is actually eligible for individuals who are, gosh, I think this is incorrect, post-pubertal, because I think young children can also qualify for it as well. So I want to validate that piece. But I know it starts in young children all the way up to 40 years of age where their tissues can actually be preserved. And what this benefit does is it allows for the preservation of their fertility tissues up to, I think, 5 years. So they can be cryopreserved for individuals who qualify for this. Very young children who may go through this, and we have post-pubertal here, but Brian, I'm really sorry. I think it goes to younger than that is what we discussed. Maybe I'm wrong.
I think we've been through discussions with CMS and gone through it, and we may change in the future, but as it's approved right now, that's the case. But we could go through a different revision.
Thank you. It just wasn't driving with my memory. I'm sorry.
No.
Thank you for that update. So for right now, it's post-pubertal individuals up to 40 years of age. And we're looking at some broader age ranges for that as well. As we know, the science has advanced even since we originally submitted this waiver request to be able to preserve some of these tissues for very young and also make this successful for older individuals as well. Next item that we wanted to just present was the in vitro fertilization and genetic screening. This came through 2020 legislative session. And what this does is it allows Medicaid to reimburse for genetic screening for both an individual and their partner for people who are carriers of certain genetic conditions. So the member must be Medicaid enrolled and have one of the following diagnoses: cystic fibrosis, spinal muscular atrophy, Morquoi syndrome, and myotonic dystrophy, or sickle cell anemia. The goal of this is to be able to identify individuals at risk, do genetic screening on them, and then be able to, through in vitro fertilization, select the genetic materials and the IVF, include all of the necessary steps to be able to choose the specimens that are less likely to pass on those conditions. So these benefits do include a full host of IVF procedures, including pre-implantation, preparation, retrieval of genetic materials, embryo growth and transfer, pre-implantation genetic screening, and counseling with an individual, and then IVF implantation. So that is now available to individuals. Both of these procedures will follow through a prior authorization process. However, the top procedure, fertility preservation, is a pretty time-sensitive procedure. So we are going to work through that very quickly and be able to authorize that as a post prior auth. So we're excited to launch those this month. Next, I wanted to give an update with where we are with our Change Healthcare cybersecurity incident outage, specifically as it affected our pharmacy point of sale services for the fee-for-service Medicaid program. So as just a little recap of what happened February 21st, Change Healthcare did undergo a cybersecurity attack and have a ransomware of their system in which all of Change Healthcare operations were taken down on February 21st. And this is, of course, very extensive across the healthcare system and had a broad impact nationally. For us in our state, of course, and specifically to the Medicaid pharmacy operations, we for 3 weeks were unable to process any claims through our pharmacy system on the fee-for-service side. This impacted, just to note the level of impact, about 65,000 individuals per month do receive a prescription through the fee-for-service pharmacy benefit. About 150,000 claims are processed monthly. So it was a pretty significant outage and impact to Medicaid members. There was great effort on behalf of our community pharmacies who do fill these prescriptions, as well as our managed care partners, our ACOs, to really build workaround operations and be able to provide continuity of care, which we've covered in last month's update. Where we are today is that on March 13th, we were able to get a system, ensure that our data was cleaned and in a secure place, so it could be placed in a new environment. That was a part of a staged process to really bring our pharmacy services back online. In this first implementation step, in this other environment, pharmacy claims are able to process and actually get an adjudicated amount back, but we still have limited functionality beyond that process. Right now, where we stand is that we are unable to receive an updated drug list, which also includes updated pricing metrics. We normally do this on a weekly basis and are able to manage our preferred and non-preferred status on our preferred drug list. Additionally, we do not have any prior authorization functions. And so at this point in time, without the ability to really update a preferred drug list or manage it and also have any prior authorization functions, we have continued to lift many of the edits that normally would occur when pharmacy claims adjudicate. As such, Medicaid members are able to get things through the fee-for-service benefit without any prior authorization at this point, and many of those sort of early refill edits and things like that. With regard to timeline of what we're working with Change Healthcare to reinstate some of these services, we believe that it will be a May timeframe when these, at least the preferred drug list functions, would be reinstated, and looking at maybe a June-ish timeline for prior authorization. So we will sit in sort of this, phased in approach with fortunately operations that do support claim adjudication and payment to our pharmacy providers. But unfortunately, some of the controls that we normally operate our pharmacy program on. An additional thing I'll note is that this does have an effect also on our pharmacy rebates. Change Healthcare does run our rebate operations for the state. And one thing that has happened since the system went down, we have not been able to even invoice pharmaceutical manufacturers for our last quarter of 2023. And so we believe and have been told that Change Healthcare should be able to start that invoicing of rebates and managing our rebate operations by the end of April is their goal. So hopefully by next week, the invoices will go out to manufacturers and they'll be able to reinstate the rebates and things like that. So it's kind of a slow go with us. In the meantime, we do have our staff watching claims and building up systems and things like that to make sure that things have ongoing continuity for members and are able to continue with our operations in the manner that we can with limited function. But fortunately, we are not hearing complaints, and our pharmacy providers do seem to have been able to catch up with billing Medicaid for all of their services that they had provided during that outage. And we believe that most importantly, members are still getting their medications and pharmacy providers are getting paid. In the context of this event that has happened, and we know that it will be several months to a full reinstatement of services. It is that point in time where we were also ready to post a new point of sale RFP to solicit for a new vendor. And this just seemed to happen around the time Change Healthcare did have their incident, but we had already been planning to post an RFP. And so that was posted in early April, and it will stay open for applicants through May 20th of 2024. And that will provide point of sale as well as our whole pharmacy benefit services. Okay, if there aren't questions on that, I'll quickly touch on some changes that happened with our CHIP premiums that are going into effect in July, but wanted to give you notice now. So you may have been aware, and may have announced this previously, that on October 27th of last year, CMS did announce through the Consolidated Appropriations Act that we are prohibited from terminating CHIP coverage for failure to pay premiums during a 12-month continuous eligibility period. And at this point, this does not align with Utah's policy. And so we need to make some changes. So effective January 1st, Utah did continue to charge premiums, but we did align with CMS practices by keeping cases open, even though the family may not have paid their premiums. So we did continue to charge premiums, but at that point, we looked at our policies and said, well, since we cannot terminate someone for failure to pay, we wanted to look at what that policy looked like and how we could maybe operate it a little bit differently. So we are in the process of updating our policy, state plan, and administrative rule so that premiums are eliminated altogether. And the announcement we wanted to make that on July 1st, we will be altering the way that some co-payments and deductibles are billed to members today, and these will increase to compensate for the offset of not charging premiums anymore. And so this will allow us to be aligned and be compliant with the requirements from our federal side, but we will also then be able to maintain some of the responsibilities that families have had with being in our CHIP program that do allow them sort of that step up out of Medicaid and preparing them for a commercial plan as they kind of move through that pathway by having some responsibilities, continued responsibilities around copayments and deductibles. So we do have a communication plan that will be forthcoming, that will be sent to members as well as posted on our website and worked through our stakeholders, but wanted to let you know now that this is in the works. And so we'll take any questions on that now or later. I just have one last point on this. And then I'll take some questions on this portion of my presentation. Last piece is, as you are aware, and we've presented earlier, CMS does have requirements for states to report out on their core set measures, both on the child side and on our adult behavioral health side. These are mandated requirements for states and that are expected to go into effect, by January 1st, 2025. I have the wrong year there. But as a result of this requirement, we did want to let you know and communicate that we have awarded a contract to a vendor who will be our certified core set reporting contractor for the quality pieces, and that has been awarded to OnPoint. So we are going through contract negotiations to finalize that piece right now, and then it has to be approved by CMS. One thing that will happen with this contract is that core set reporting will not just be sent to CMS as part of those requirements, but one of our plans is that we will have this dashboard created through this vendor, which will have the reporting for the core set elements, both on the child side and the adult side, for public viewing. And we do have some pieces of that available now through our healthcare statistics group, but this will be officially put through our Medicaid channels in future months. So wanted to let you know, right now we do have some of these elements broken down by plan. We do intend to also have our fee-for-service clients represented on these core set measures as well. So there's transparency on how our patient population is doing through the different HEDIS measures that are within core set. So with that, I'll take some questions, and then I'm going to flip over to my last piece, which is a quick update on timelines for implementing the legislative items that came through this past session. Go ahead, Stephanie.
Yeah, thank you for all of that information. I'm just curious if when you all have been working with CMS on the CHIP premiums going away, have they talked about any other cost sharing mechanisms, like for the disability population, the ABD, and like the MWI anyways, and like, have they talked about any of those? Also, like, are they looking at exploring decreasing the cost sharing of those population groups?
Go ahead, Brian.
So no, not to my knowledge. One of the clarifications is premiums are actually still allowed. It's just states could not close individuals if they do not pay premiums, which doesn't make a lot of sense for us, which is why we've decided not to charge premiums effective July. But so it is not necessarily a prohibition on charging premiums wholesale. It was just on the closure. So there, I mean, future policy could change, but no, we have not heard about prohibiting other types of cost sharing. Andrew?
So, Brian, you just triggered a question for me, and that is so it doesn't make can you close or take other action if a family doesn't pay a copay or meet the deductible? What is the advantage to you all of doing it on the other end?
For CHIP specifically,
Yeah.
It's no change in the policy, and we do. I mean, those cost sharing elements are collected by the provider, and there is policy we do have of like inability to pay should not reduce a provider's delivery of care. I can try to pull up the policy just for further clarification, but no change in that policy of it's not an enrollment factor. It's just it's collected at the delivery of care site.
So, and I can look through the policy. So I'm not, if it's in the policy, I'm not gonna make you do all the detail. I'm just curious, what the state sees as the advantage of if somebody can't be disenrolled, what advantage the state sees in maintaining the requirement to pay copays or deductible. And I understand the philosophical idea of preparing somebody to transition to the private market, but in reality, what's going on here?
Yeah, I can attempt. I mean, I think you started to take the answer out of my own vocabulary as you spoke. I mean, CHIP has been kind of a stepping stone between Medicaid and the private market. So we did compare as we compared cost sharing elements in other commercial plans, like for employees, there's a public employee health plan, PHP, that we compared against, making sure that the cost sharing requirements are still less than that. But it is meant to be something of a preparation for commercial insurance as individuals do transition to higher income levels, to be prepared to know what coinsurance, copayments, deductibles mean and how it impacts them.
Okay, thanks.
Thank you, Andrew.
Okay, if there are no other questions, I'm going to just really quickly run through the presentation that was shared with you last, I'll just share my whole window here, time, which had our legislative breakdown of the items that we had. Michael had asked if we would just walk through the timelines for implementing the various items. So much of what you'll see here is sort of a slimmed down version. I took out some of the details so it was less chunky, but less busy anyway. And I wanted to just walk with you through quickly on what our timelines are for implementing the items that came out of legislative session in 2024. So just to know, in red, I have called out the date by which the policy or rate increase will be implemented. So you can quickly refer to that. Just below here are rate increases as we start at the top, which will be put in place on July 1st. There are more here, but using our reference from last time, wanted to just capture the pharmacy dispensing fee increase, nursing home Medicaid rate increase, the cover for ambulatory medical detox. This was a new code that is more of a bundled rate for a service for ambulatory medical detox that will be live on July 1st and reimbursable at that time. And then the increase for the mileage for ground ambulance as well will all be active and increased in our system on July 1st. I wanted to walk through some legislation and bills and the timelines for those when they will be implemented. This HB 38 looked at the two different things. It looked at, first of all, the Utah Psychotropic Oversight Pilot Program, which is a consultative service run out of the University of Utah Psychiatry Department, where pediatric behavioral health specialists do work for both DCFS as well as JJYS new is a new service underneath this, and look at the medications and the prescribing of psychotropic medications. That is just an extension of this service, which was supposed to sunset. So that will continue forward, but an important rate increase that will occur is for our behavioral health carve-out services for both our foster care and JJYS folks that were run through the carve-out on the behavioral health services. There was a rate disparity that occurred from the Medicaid fee schedule. And that disparity will be changed on July 1st so that this and all future rates for these providers will be aligned with the Medicaid fee schedule. HB 392, the nursing care facility modifications the rule will be submitted by July 1st, 2024. So that effective date will be aligned with the policy so that this bill can be implemented on July 1. The many aspects of HB 501, first of all, with our justice waiver addendum that we mentioned, will be in place on July 1 to go into effect so that services would be available 90 days pre-release for individuals who are Medicaid eligible in a carceral setting. Also, that bill included a third-party liability collections to be applied to a primary payer when a prior authorization is on a service and Medicaid pays for it. That rule will be submitted actually sometime in May, but to be effective closer to actually July 8th. That will support the rule for that. Go ahead, Michael.
So just, question on that. In addition to your processes of just publishing a rule, what outreach are you doing to commercial insurance companies to make sure they're aware of this change and their obligations? Because as we've talked about previously, this kind of puts the commercial insurer and the providers in a situation of going back and forth and takes Medicaid out of the payment equation and just trying to avoid a lot of back and forth saying we as a primary payer don't have an obligation as the commercial insurance person entity for a Medicaid covered individual that has a secondary benefit under Medicaid where they might have some other payer.
Yeah, so a few things that are happening. First of all, ORS is also updating their rules, so the notification will come through ORS, but we have already met with the Department of Insurance, as well as having PEHP on board so that we can work through that network, through their networks, as well as talk about how we can interact with providers who would be submitting the PAs, right? So I think working through the Department of Insurance and making sure that our communication is aligned and that we have messaging going out through the Department of Insurance is one pathway that we've already met on during legislative session and agreed to have notification education through that panel. And then also making sure that the provider networks are also engaged and knowledgeable of these changes as well. If you have other recommendations, I'm happy to take them. We're happy to take those too.
That's great. Thank you.
Okay. Yeah, you're welcome. Also in HB 501, also included a primary care rate increase on select codes, and that increase of 2.1% on primary care rates will go into effect also on July 1st. SB 26 did define many different new provider types that would be available to support behavioral health services in our state. And it creates several different licenses and changes scope of practice, as we've covered in prior meetings. One piece that we are waiting on is DOPL does have 180 days after May 1st to do its work to accomplish the work that was outlined in this bill. However, Medicaid is working to have PRISM programming as well as our state plan amendment submitted by July 1st. So we've already outlined the change requests that would be needed to make sure that our systems can accept these new provider types. When DOPL finishes their work, our system will be ready for that. And we will have our state plan submitted by July 1st to accommodate these changes and support the updates for these provider types. Go ahead, Stephanie.
Thanks, Jennifer. I'm just curious, do we know how much like certified peer support specialists, so within like these other provider types, like like if there's like a, I guess like a umbrella of like where they all fit, is it going to like, are they, I guess like is reimbursement rates, do reimbursement rates need to also be raised for certified peer support specialists to like, because of all of this, or is there like any conversation about that just with like these other provider types being in, like, I don't know if that's making sense. Like these additional provider types, are they like, we wouldn't want to see like people go into one provider type and then like avoid other provider types that are also helpful. Like, does it allow for like, I guess, is it like competing with peer support specialists, or I don't know how to kind of ask this.
Yeah, I think that's a good question. I may have to take back, and we can walk through with more detail this specific policy when it's fully developed, to look at the reimbursement rate for these provider specialists. And then we can address your question around peer support specialists and where they may fit. I was just trying to scan quickly if Dave Wild was on the call, and I really would love our behavioral health counterparts, unless we have one here. But this work is, the policy work itself is still being done and worked through, Stephanie. But as we're ready to present it, we'll bring those details back, and so we can answer some more of your questions, if that's okay. Brian, go ahead if you want to speak to that now. I know we don't have the policy finalized, but.
Yeah, no, I overall totally agree. Just one small thing in the interim, I will just say that they're not necessarily mutually exclusive. Some behavioral health coaches are former peer support specialists. It's part of the documented training that could make someone become certified as a behavioral health coach. But overall, totally agree. We will bring that policy back when it is ready. Thanks.
Yeah, thanks, Brian. And Stephanie, I think your questions are really good ones, and we want to be thoughtful as we're looking at how it affects the whole scope of things, and also reflect what that study that was done was aiming to achieve as well. So I think we can bring it back for more policy presentation in the future, and we'll do that in a future meeting. All right, just to keep running through our items here quickly, behavioral health system amendments. Again, we're looking here at significant changes. HB 413 working group did have its final meeting. They did sunset this work group through this legislation, and we did have our final meeting on March 22nd. We do have two changes that occurred with regard to creating the Behavioral Health Commission, as well as moving the Substance Use Mental Health Authority into DHHS. Those are happening on May 1st. So that work is being done and is already in play, and those things will happen when the legislation is moved into authority. SB 32, caregiver compensation. This allows a step parent to be reimbursed as a provider of services under caregiver compensation, and that is going to officially be live according to this SB 32 on July 1st. Native American health amendments. This had a timeline of January 1st, 2025. As soon as we're done authoring and moving our HRSN and our justice work through the July timeframes, we will right away begin our work on Native American health amendments, and we're looking forward to that. We will have our things submitted well before January 1st, but the timeline on that is January 1st. Medicaid, last but not least, SB 197, Medicaid reimbursement rate amendments, which allows autism providers to benefit from that 2% increase that the ACOs and behavioral health plans do get. When the legislation came through, it would put a timeline of July 1st, 2025 for the autism and ABA codes to be eligible for that 2% increase. And so those rate increases would go into effect on July 1st, 2025. So that summarizes sort of our legislative items and where we're at with our planning and implementation of these. If there aren't any other questions, thank you for the time today. Go ahead,
Sorry.
Stephanie.
No,
you're good.
Of course I have more. I wanted to know if the CMS has had a role about beneficiary advisory groups, and then also renaming the MAC. And it's like all a part of that proposed new rule. And I just wondered like where the agency is at with like various pieces of this being, discussed, planned out, implemented, etc. That's my first question. I have 3. Sorry.
I personally haven't been in any discussions, Stephanie, yet with regard to the work around renaming the Medical Care Advisory Committee. Brian probably knows about work that's being done that I haven't been briefed on yet. So Brian, if you could just give a little update. And I know if this is tied into the eligibility rule that was released and access rule, we are going to be delivering an update to that in a future meeting, but we weren't ready for it today. So we have a formal report out that we'll do in the June meeting on the eligibility and access rule. But go ahead, Brian.
Yeah, thank you. Yeah, the changes to naming for the Medical Care Advisory, this body that's part of the HCBS access rule, which we are expecting soon. I've heard an expectation of April, but there's no guarantees. And yeah, it would rename the committee to the Medicaid Advisory Committee and create a beneficiary, I think, access group. I think that's as well. We are doing as much pre-planning in limited scope as we can, but like we are just anticipating that most of our planning can really take off once the rule gets finalized.
Yeah, I think that's an important clarification. What's out there right now is just a proposed rule for public comment. They take the public comment, then the agency would have a chance to implement what's actually happening, and it's not been a finalized rule yet.
Okay,
All right,
thank you. for
Stephanie,
that.
question number 2. You said you had
Question
3.
number 2. I do. Last month, whenever I had asked about the recommendations and response from DHHS and DWS related to like eligibility and enrollment that some of us had meetings with you all about, I was told that in, I believe, the next, I don't know, it was something that was like, we're going to discuss that next month or the following month. So I'm just wondering if y'all have any information on that, or if that's going to be further down the road.
I would say we have an update in future months. We have lots of activities that are ongoing right now regarding the questions that were presented to us by the MAC as well as through Representative Judkins. And so I would say we have a lot of work at play. We'll report out on those in a future meeting.
Okay. And then lastly, for the budget presentations, I couldn't remember if this is something from last year or not, but was there any changes to what you all wanted for the budget presentations for next month, or like a specific template or specific things that you all were like wanting the budget presentations to cover? I couldn't find in my notes, but I thought there was something said last year, and I'm just like trying to remember if I am right or if it's just like I could be misremembering.
Maybe ask Sharon, who's collecting those. Sharon, has anything changed from what we had previously?
So no, nothing has changed. Sorry, maybe I don't understand the question, Stephanie. I mean, people have been signing up to present next week or next month at the budget recommendations. And it's just, they're bringing whatever services that they would like for the MAC to consider.
Michael, do you remember anything? I guess I just thought there was like a template or like specific criteria that was supposed to be included.
I can look back to see what I did for mine last year, because I did present last year. I can look back to see. I think it's pretty loose. I think just don't make it 30 minutes. Probably try and keep it under 5 minutes. And then I think my biggest thing was trying to make my request be enough. It had to be a certain amount of letters. like, or characters rather. I think that was the hardest part for me because mine was long. Maybe I just don't know how to spell very well. I don't know.
So,
But yeah, Steph, I can give you what I did last year.
so, and let me clarify. I guess I thought you were meaning like what you could present on. We do have a budget questionnaire that we ask presenters to complete. This helps our finance staff with coming up with the estimated, budget of, less than $1 million, over $1 million, that type of thing. So there is a budget questionnaire that we ask. Because of the amount of people that I've had sign up so far, presentation should be like limited to 5 minutes. It's probably what it's going to be, like we did last year. If you have any other speakers that you want to kind of support, just send me an email and I can help walk you through any of that. The materials are due by May 8th. Like I said, we do have the budget questionnaire. So yeah, just shoot me an email for anyone who wants to sign up to present next month in May. Just go ahead and shoot me an email and I can walk you through what is needed.
Good. All right, and to that point, just as a reminder, this is at the bottom of the agenda, but for those of you on your first year on the MAC, our meeting next month will be the same third Thursday of the month experience, but we will meet from 4 p.m. until 6 p.m. instead of our 2 to 4 time, just to allow people who have full-time work and may not be available to come in the middle of the day to be able to come and present sometime between 4 and 6 p.m. So that is the only time variation that we have for this meeting each year. So just want to make everyone aware of that and have that reminder. Okay, our last topic on the agenda is open time for committee members to share any experiences they are having to, yes, to your question, Colleen, it is on the 16th of May. Any interactions you're having with individuals you have most contact with as they're experiencing the Medicaid program, and bring any issues to the table for the committee to be aware of and discuss. So let's open up the floor for anybody to raise any issues or bring things up. Andrew, we're going to hold on you for just a minute until we make sure everybody on the committee has a chance to respond. Okay, let's go to you, Andrew, and then I have a topic I wanted to bring up.
Thanks, Michael. I don't have anything to share. It was just in probably an unhelpful response to Steph's earlier question about what is hoped for in the budget hearing. And Steph, I don't remember if this came from the committee last year, or if it is just, or if I'm just imagining it, because it's something that it's a pet peeve of mine in other settings. But one thing that you might be thinking about is, I think the committee in the last year or two has really asked folks, to the extent that they're able to present what the anticipated outcome or impact of their request is going to be. And that might be part of what you're thinking about, but I'm not sure.
Yeah, I think you're right, Andrew. It's probably that.
Okay. Thank you for the insights. Okay, one of the things the MAC is in charge of doing is reviewing administrative rules or state plan amendments we've had come before the MAC. And so that gets distributed in our mailings prior to the meeting. We don't like have a standing issue to talk through these. But I was just kind of looking through those that were sent out yesterday on the state plan amendments, and I guess was a little surprised at the expediency with which the department is moving on the high drug carve-out proposed state plan amendment language. So Jen, you had mentioned on Monday that you were thinking about this and were soliciting some feedback from hospitals about what their thoughts were on it. So I was a little surprised to see that a proposed effective date of next Monday was the timeline on the state plan amendment, and the operational implementation requirements and a number of things in terms of billing that so differently in the future, and was just trying to get a little better understanding of your expected timeline for implementing that program, as at least it was presented in the state plan amendment language.
Yeah, certainly, Michael. So you may recall that we are working to develop a more comprehensive policy around cell and gene therapies, which we're calling ultra high cost drugs. These are drugs that we define as more than $1 million per dose. And last year, these drugs had been carved out of the managed care plans and brought to fee-for-service as part of a policy change at that time. And at the same time, the state was also pursuing with CMS the opportunity to have authority to negotiate value-based agreements on these products. And with that role, both carving them out of the managed care plans as well as being able to seek value-based agreements, part of that dialogue was the ability to bill for these products, number one, and have fee-for-service pay for the drug that might be in an ACO, otherwise ACO billed DRG, right? And how we would manage that operationally. Additionally, one of the components of value-based agreements is to have greater transparency on what those products look like, so that there is the ability to get the invoice and be able to see the invoice, so that we can keep the value-based agreement intact and fulfill some of the requirements that are laid out in a VBA. We do not have a value-based agreement on any cell or gene therapy or ultra high cost drug at this point in time. The work that had been looked at and the first step had been done last year with regard to carving them out of the plans. Our continued process on working on sort of an SOP on how that would process would take place with if one of these drugs were to be if there was an individual who'd be eligible for one, and then what that process would look like in working with the plans. One of the next steps that we had looked at, and what Michael's bringing up, is the announcement on a state plan to update our state plan to reflect some of these changes, not just to carve them out of the DRG, but how they would be billed for. And I do think, Michael, that just got a little ahead on this notice before we had been able to actually socialize that. It was on my agenda to walk through those components with the hospital association this next week. And so I think those conversations need to happen with stakeholders and dialogue about what that process change would look like, how we work through those components, and kind of the rationale of why. And so I think some of those items got shared, and we need to still have those conversations. So
yes, that's a much more comfortable approach. Yeah. If we are not expected to have an effective date of next Monday, when we've just learned about the process this week, if we can just slow down the engine on the train and understand what's involved with the billing and have a chance to talk through it before it goes out. That's what we're looking for at this point. Okay.
Certainly. And I think we're still in making sure that the system is well informed and has ability to get feedback on it through that process. So just wanted to let you know about that. And then Stephanie, specifically, how does this impact beneficiaries? with regard to the state plan, maybe I'll let you respond first, Michael, on that, unless you prefer that I do.
Oh, no, sorry,
Yeah.
I didn't ever go to mute, but I
Yeah.
understood. So please.
Yeah, in the context, what our overall policy is when it comes to cell and gene therapies, first of all, is with the beneficiary in mind, but to really be able to have accountability at the state level to manage these drugs appropriately. I think it's, first of all, our interest as these novel therapies come to market. First of all, what we know now, the cell and gene therapies are really more designed for rare diseases. What we see in coming years is certainly that they are going to become much more widely available for more commonly seen diseases that do have a genetic component that may have a solution. And what our interest is in doing is really building up a better system of care and accountability mechanism when individuals receive this. This state plan amendment didn't have a specific beneficiary lens in it in the way that this specific step was designed. Other than that, we're trying to build a framework so that we can have solid value-based agreements and accountability with the manufacturers when we invest what is, with Hemgenics, like more than $3 million for a dose of this product, or one of the drugs for sickle cell that is also a $3+ million price tag, that the right person is selected for these therapies, and that when the person receives these therapies, when in a value-based agreement arrangement, that there are clearly defined clinical criteria that can be monitored along the continuum, so that we want to ensure the drug holds its patency, but in the event that it may not do that, that there is a mechanism in place with accountability for the manufacturer to pay back the state or the payee for that investment in this service. So in this particular instance, it's more around the body of work that's needed to ensure the right controls are in place, that the beneficiary can get the product, but that if in case a value-based agreement is in place and that product does not hold its efficacy over a defined time frame, that we are able to get some money back with regard to the investment that was made in the product to ensure that it would work, but when it failed to do so. So that's the context of kind of building this framework up around how the drugs are administered, how they're paid, and the transparency around how that cost was, and the design of that program. And those are some of the steps that you're seeing through this process.
But it wouldn't have any impact on cost sharing for the Medicaid enrollee at the point of service, just overall sustainability for the program and access to the drugs, I think, is probably the biggest impact.
That's right. Thank you.
All right. So there's a question that came in. Carlos, I'm not sure why you're wondering if someone from ORS is on the call. We don't necessarily have someone assigned from ORS to take questions, but we can ask. Is there anyone from ORS who's joined the call? Okay, do you have a specific question, Carlos, that we could coordinate with ORS on? Is there a particular problem as it relates to Medicaid collections or something you're looking to address that we could maybe follow up for our next meeting?
Yeah, no, that's okay. I was just wanting to ask a general question about Medicaid, and when somebody applies for Medicaid, how that, I guess the interaction between that and ORS. But that's okay. I was just wondering, in case anybody from ORS was here. That's fine. Thank you.
Okay. Yeah, and I'm sure that we could get some question to ORS and get an answer to you if you'd like to submit that for us, and we can coordinate a response if you'd like.
Sounds good. Thank you so much.
Okay, thank you. Okay, any other committee member comments or updates for the group? Okay. Well, thank you everyone for joining today. Thank you everyone from the department for your presentation of information, asking our for answering our questions and providing all of the presentations that have been shared today. And we will plan to get together next month at 4 p.m. on May 16th. Okay, thank you. Bye.
Thank you.